Well, welcome everyone to our spring webinar. We are so glad that you take the time out to join us. We like to have these webinars quarterly as really a way to let you know really what your information is being used for when you spend time filling out surveys and joining DS Connect. We like to then highlight researchers who have actually used this information and talk a little bit about what they've found and how they're contributing to improving the lives of people with Down syndrome. So with that, this is a shameless plug to go in and complete more DS Connect surveys as you have the opportunity. So when you register, everyone is prompted to complete this basic health survey. And based on your questions or your answers to the basic health survey, additional surveys may be populated in here. And then this helps researchers who are specifically studying, say, diabetes or celiac disease, to have the answers that they need to be able to then formulate additional questions. You can also submit any suggestions to info@dsconnect.org. Researchers can use the Tools for Researchers tab on the website to submit completely new surveys or ideas for new surveys as they come up. We also wanted to highlight upcoming events. This is where you can connect with the DS Connect study team and community. So this year we are really focusing on expanding our community outreach. So if you have questions or would like us to come to an event, please don't hesitate to reach out and let us know. We're happy to brainstorm with you on ways that DS Connect can help support your event and then be at the table or have a table and give back. So you can see a couple places where we're going to be coming up here. We'll be down at Emory and in Denver here this summer as well. So please reach out and let us know where you'd like us to see you at next. And with that, we will start our presentation. So you'll notice that the chat's been disabled. If you have any questions, please feel free to just drop them in the chat as they come up as Dr. Brown is presenting. So others won't be able to see these questions. We may choose to answer them live. If we don't have an opportunity to get to all of the questions, we'll definitely follow up by email. So everyone after this, everyone who is registered will receive a copy of the email or a copy of the presentation. And in that will also be a link where if you haven't already signed up for our newsletters to stay in touch with DS Connect, you can do that as well. So with that, I would like to introduce the reason that you are all here, Dr. Brown. She is a licensed clinical psychologist and assistant professor at Virginia Commonwealth University. So Dr. Brown has worked with individuals with Down syndrome since 2013. She works closely with both individuals and their families to address issues of stress, anxiety, depression, and by formulating really compassionate and self-care. With that, I will hand this over to Dr. Brown to get started.
Thank you so much, Angela, and thank you so much to DS Connect for having me here today. It's always a joy to be able to kind of share back information that we've been collecting through research and to be able to give that back to the community. So just really, really happy to be here. Give me a second to get my slides up. All right, great. And then let me minimize my picture there. Okay. All right, so I'm going to be talking today about what we've been learning about recognizing mental health symptoms in people with Down syndrome. Let's see, whoops, there we go. Okay, this is my lab, the Hope Lab at Virginia Commonwealth University, and my just amazing team of my research coordinators and undergraduate students and volunteers who just do amazing, amazing work in supporting the mission of the lab to help improve outcomes for people with intellectual and developmental disabilities with a particular focus on Down syndrome. Okay, so I'm going to start with what we know already about mental health in people with Down syndrome. So studies pretty consistently show that people with Down syndrome experience heightened risk, kind of elevated rates of anxiety disorders, depression, and in particular depression with psychosis. So that may mean that just during a depressive episode, they may experience symptoms like hallucinations, or kind of delusional ideas. Down syndrome regression disorder and catatonia are two conditions that have been kind of more and more recognized recently and have getting a lot more attention. They're much more severe, but they're also much more rare, and so those are also important things to consider. So I'll be touching on those. But let's start to kind of talk about like what do these mean? Like when I'm saying like anxiety, depression, like what does that mean, and how might that look different in a person who has Down syndrome? Maybe particularly if they have different communication strategies, their symptoms may look different, and so then they may be less able to communicate their symptoms, and so then healthcare providers and family members and caregivers need to be able to kind of recognize some of those symptoms and understand like what that might mean for that person. The first one that I'll start with is specific phobia, and this one is one of the more common of the anxiety disorders. A specific phobia is an intense fear of a specific object or situation. So this might be somebody who's like has a fear of dogs, and so it's pretty limited. Sometimes people might have a few things that they're anxious of, but usually they're just kind of one thing that causes them intense fear. And so then the fear that's associated with that thing is just out of proportion to the actual danger. So they may be afraid of like going outside because there might be a spider in the grass, for example. How it might look in Down syndrome especially if they're unable to kind of communicate what it is exactly that they're afraid of. You might see intense avoidance of certain places or people or activities. They may have kind of tantrums or shutdowns when faced with the feared object, and so if they see a spider, or if they kind of hear about storms, like on the news report, they hear that a storm is coming. They may kind of overreact. They may hide. They may, or just have a complete shutdown, and that can be hard for caregivers to then understand what it is that they're afraid of. And so people with Down syndrome may have difficulty explaining verbally, kind of what those symptoms are. And this is going to be a theme, I think, across all of these, is that, the more difficulty they have with, describing what they're thinking and what they're feeling, the more that's going to be shown through behaviors. And so then we have to become like behavior detectives. Okay, social phobia is another type of anxiety disorder. It's also called social anxiety disorder. And then this is a fear of being in social situations, but it's specific to being afraid of being judged or being embarrassed in these social situations. And so for a person with Down syndrome, that might look like a kind of refusal to participate in kind of activities, group activities, even if it's something that they love. So maybe they love singing and dancing and performing at home, but then they join a class and then they suddenly don't want to participate in the class, or they don't want to go on stage. Sometimes it can be really specific to a specific social situation, and we call that specific social anxiety. And so maybe it's like performance anxiety, they get stage fright. And so otherwise they're fine in their life. It's just that kind of one event. But sometimes it means that there's a really important event to them that they'd like to be able to do, but they're unable to do because of the anxiety. And then we would want to address that. Sometimes people have generalized social anxiety, where they're just afraid of almost all social situations. And so they may feel anxious going to the grocery store. They may feel anxious ordering food at at a restaurant. And so they may be afraid of, just introducing themselves to somebody. So you might observe that by, again, kind of seeing them kind of clinging to familiar adults. They might kind of hide behind, their family members. They might, kind of shut down or refuse to talk even though they can talk. So those are some things that might indicate that they have a social anxiety disorder. Generalized anxiety disorder is just a lot of worry, kind of a worry about many, many things. And so they can just, they're kind of worrying about school, they're worrying about their family members, they're worrying about their future and what's going to happen to them, what's going to happen to others. They're worried about what's on the news. And so it's just a tendency to worry. And that worry is there almost every day. People sometimes call, like a term that's used for people with generalized anxiety disorder is kind of walking worriers. So they just are kind of worrying all the time, and that worry is very hard to control. People with generalized anxiety tend to be very restless and have difficulty with falling asleep because their mind is just racing, and they may be irritable as a result of that. They can experience trouble concentrating or feeling like their mind is going blank because their mind is just always, kind of, focusing on their worries. They can also have muscle tension as a result of that. And so people may have, kind of tension in their neck and shoulders. We don't see that quite as often in Down syndrome, I think partly because of the low muscle tone. And so the muscle tension may not be as much of an indicator. And then sleep difficulties that are not due to sleep apnea. And so some other characteristic ways that we might see, kind of anxiety popping up in people with Down syndrome is a lot of repetitive questioning about their daily routines, or about whether or not they're safe. They may seek a lot of reassurance from their family members, and some of that's through that kind of repeated questioning, but it's that need to feel like they understand and they know what's going to happen and, what their day is going to look like. You may see some other physical symptoms like stomach aches or headaches, and then irritability and restlessness can be a sign of anxiety. Obsessive compulsive disorder is another one, and this one is also kind of more common in people with Down syndrome, or at least obsessive compulsive tendencies. So when we talk about the disorder, like OCD as a disorder, it's characterized by unwanted and repetitive thoughts, those are the obsessions, and then repetitive behaviors or compulsions that are performed specifically to reduce the anxiety. And so those things, within OCD, within kind of true OCD, are tied together. So the compulsive behaviors are there in order to address the obsessive thoughts. It's very time consuming. So people with OCD engage in these compulsive behaviors for more than an hour a day, and it causes them extreme stress and interferes with their daily life. So these are not compulsive behaviors that they're doing because they feel good or because they enjoy them. They're doing them because they feel like they have to and they can't control it. So in Down syndrome, it can look like, kind of repeating certain actions, checking doors, arranging things, washing or cleaning things excessively. There are reports of people who have an obsessional slowness because things have to be just right. And so this isn't obsessional slowness or kind of slowness that's associated with catatonia, which we'll talk about later. This is, otherwise they're fine, but they have certain rituals that have to be done exactly right. And the purpose of it is to try to do something just right. We see that sometimes through like an insistence on, kind of routines or sameness, and getting really upset if these kind of rituals or habits are interrupted. They may feel like they have to go back and start all the way over from the beginning if it gets interrupted. It may be mistaken for kind of rigidity. People with Down syndrome have often been described as, liking to have routines, and sometimes those routines are actually helpful and beneficial to them. And so if it's a routine that's helping them and giving them a sense of, of predictability, then we're not usually as worried about that. But if it's an anxiety-driven ritual or routine, that's when we get worried, because then it's causing them distress, or it's causing, their friends and family, distress. So there's some real diagnostic challenges when it comes to determining if something is an obsessive compulsive disorder, or if the person just has, kind of obsessive compulsive tendencies. And some of those specific challenges for people with Down syndrome or other intellectual disabilities has to do with being able to assess their obsessional thoughts. If their verbal abilities are limited, they may not be able to tell us kind of what it is that they're thinking. Like, are they having some thought about some harm befalling them, something bad happening to their family members or loved ones, thoughts about being dirty, or thoughts about, bad things happening. Like, they may not be able to communicate that to people. And so that can be hard to determine. And then it can also be hard to determine if those thoughts or those compulsions are distressing them. And again, are they doing certain rituals because they're calming and relaxing and because they enjoy them, like they like to clean and tidy. And so, that they spend a lot of time kind of going along, tidying because they enjoy it, or is it because they feel like they have to, because if something is out of place, there's something wrong, something bad is going to happen. And they're doing it out of a sense of they have to do it rather than they want to do it. So we would be really looking for signs and symptoms that they're experiencing distress, that they're getting angry, that they're getting upset, and that they're, experiencing that distress to know, or if it's significantly interfering with their daily activities, like they can't leave the house to go to do even something that they would love to do, something fun, because they have to complete their entire routine that's maybe very time consuming. Post-traumatic stress disorder is one that we really have very, very little data specific to Down syndrome, and not a whole lot specific to people with intellectual and developmental disabilities. But post-traumatic stress disorder is a mental health condition that's been triggered by experiencing or witnessing a traumatic event. So something that's life-threatening to themselves or someone else, or risks kind of serious injury or harm. It's characterized by intrusive memories, and avoidance of things that might trigger those memories. So they try to avoid reminders of the stressful event, as well as heightened then physical reactions. And so they may have heightened hypervigilance, where they're kind of checking, looking over their shoulders, or just kind of sensory overload. It's basically caused by being kind of stuck in the stress response system, where the brain is staying in fight or flight mode. So for somebody with Down syndrome, the way that that PTSD might look is kind of frequent self-talk about a traumatic event, or they may be kind of reenacting that event through play or through other behaviors. You might see an increase in a kind of aggression or outburst or self-injurious behavior after a stressful event. They may lose adaptive skills after an event. This is particularly true after maybe an abusive experience. They may be more likely to lose some of those adaptive skills. Other behaviors like non-compliance, social isolation, or sleep problems may emerge. They may have an increased startle response, or as I mentioned, that kind of sensory overwhelm. They might become just more kind of overloaded. They may engage in other kind of sensory seeking or sensory kind of avoidant behaviors. And again, and like things like avoidance or re-experiencing symptoms of flashbacks. I think a lot of people, when they think of PTSD and think of flashbacks, kind of think back to like, kind of media, portrayals of people, like war veterans kind of having like war flashbacks. For people with intellectual disabilities, there's a real concern about some of those flashbacks being mistaken as psychosis, that, especially if the traumatic experience is not known to their caregivers. And so there's, maybe some concerns that a person is kind of paranoid or, experiencing hallucinations when really the person is experiencing intense flashbacks. So this is an area that we really need a lot more research on. Okay, and then depression. Depression is a mood disorder. It's caused by persistent feelings of sadness and loss of interest in previously enjoyed kind of activity. So a person used to be engaged in, hobbies and activities. They went to Special Olympics. They loved to, to do beading and arts and crafts, and then they're just not interested in those things anymore. Not because they've aged out of them, but just because, it's accompanied with this kind of mood, this mood disorder. It can involve other physical symptoms, also like sleep disruption, fatigue, and appetite changes. And those appetite changes can be either an increase in appetite or a decrease in appetite. So in Down syndrome, a depressive episode, again, like it might be hard to recognize if the person is feeling sad because that's an internal feeling, and so, or you might not know why they're, kind of shutting themselves off in their room more. So we have to look for these behavioral, cues. And so it can involve, so in kind of more serious cases of depression, it can be include a loss of self-care skills, loss of social skills or social interest. They may be moving or speaking significantly slower than before because they're just kind of, kind of sad and moving slow. In Down syndrome, it could also be characterized by an increase or a change in their kind of private speech or self-talk. So many people with Down syndrome engage in self-talk, where they're kind of talking out loud and talking to themselves, and that can be sometimes a little indicator of their emotional state. And so if their self-talk has started to become negative and self-critical, that can be a sign of depression. Other changes in their kind of toileting or their sleep patterns can be signs of depression. And then other signs, kind of increases in irritability, agitation or stubbornness, might be present instead of just, I think we tend to think of sadness. We think of like Eeyore, when we think of depression, of kind of being, kind of just sad and crying. But, agitation and irritability are also an important sign of depression. Right. And then finally, Down syndrome regression disorder. And I've kind of put this together with catatonia because there's a lot of overlap in the symptoms. And it's not, we're still trying to figure out the extent to which these things are kind of related, whether they're kind of distinct disorders or presentations, or or they're overlapping. But Down syndrome regression disorder is really the kind of hallmark feature of that is it's a sudden acute loss of previously acquired skills or abilities. So the person kind of loses their activities of daily living, communication abilities, toileting, social engagement, where they kind of really have a significant change in their behavior. Catatonia is also is a neuropsychiatric syndrome. It's been recognized for a long time, and it's also characterized by kind of motor and behavioral changes. It could involve, kind of most people kind of think of what we call like kind of a stupor, where the person really kind of shuts down and becomes immobile and unresponsive to their environment. But there's also kind of another subtype, an excitement kind of subtype, where the person engages in kind of excessive and purposeless movements. It's important to note that both of these and this kind of symptoms associated with them can be caused by various kinds of medical conditions and psychiatric illnesses. And so those things have to be, ruled out because there may be important underlying medical causes. And that's true for, this will be something we'll come back to, this idea of getting a medical evaluation. All right, so those are the kind of main categories. There are many more kind of mental health conditions, but those are the kind of most common, the most frequently seen ones. Now, some challenges with recognizing mental health in people with Down syndrome and making sure that they get access to good quality care. One of the main ones is diagnostic overshadowing. Then this is a term that describes when one diagnosis kind of overshadows another diagnosis. And so families often report, kind of hearing from healthcare providers, oh, that's just Down syndrome. And sometimes, sometimes parents themselves don't recognize these as being, symptoms in their loved one. But even when they bring up these concerns to, the primary care provider, they get told, oh, that's just Down syndrome. That, just people with Down syndrome experience, more depression or, more anxiety. They just engage in these compulsive behaviors, rather than considering the possibility that that this is a treatable condition, that even if people with Down syndrome are more likely to have these, these behaviors or these mental health concerns, that doesn't mean that we can't do anything to help them and to help them have a better life. Another challenge is medical complexity. So things like sleep apnea or thyroid or Alzheimer's disease can trigger some of these symptoms, or can mimic some of these symptoms. And so we see, for example, people who have chronic sleep apnea, if they're not sleeping well, they're not getting enough oxygen at night, that can cause symptoms of depression. And if we treat the sleep apnea, then sometimes the depression goes away. And so that's important to address that underlying cause, because if they have sleep apnea and it's not treated, they have depression and they're getting treated for their depression, with antidepressant medications or, or therapy or counseling. If we're not addressing that underlying sleep apnea, that depression may not go away. So we want to make sure that we're paying attention to these underlying medical causes and making sure that those are addressed. As we've talked before, so some of the symptoms present differently. We think the main reasons why we see these different presentations is because of communication differences. They may not be able to, express what their what they're feeling, and then also cognitive differences. So their own understanding of, of their feelings, of their emotions, may be limited, and so they may have a harder time understanding their own feelings. And unfortunately, there's too few tools that are available to help doctors and healthcare providers to be able to make an accurate diagnosis. So given that these symptoms may look a little bit differently in a person with Down syndrome, the standard scales that have been developed, if you go to the doctor's office and they give you the, patient health questionnaire 9, to check your depression symptoms, we don't know whether or not those same rating scales will be able to detect the symptoms the same way in a person with Down syndrome. So that was part of what motivated a study that I did and finished up a couple years ago through an NIH-funded project. It was a KO8, which is the Career Development Award. It was a LEAF study. And we collected information from 127 kind of parents and self-advocates and children with Down syndrome and mosaic Down syndrome. About half of them had mosaic and half of them had full trisomy 21. And we recruited people through, Down syndrome organizations and through the DS Connect registry. Participants were 12 to 45 years old, so we're trying to get kind of adolescence and adulthood. And the major goals of this study were, we wanted to know whether screening instruments were valid for use in people with Down syndrome. We wanted to know kind of what was the prevalence of depression and anxiety, in our sample. And we wanted to know what role stressful life experiences played in mental health for people with Down syndrome. So to do this, we measured mental health using a lot of different strategies. We used a couple of rating scales, the Glasgow Depression Scale and the Glasgow Anxiety Scale, that were developed specifically for people with intellectual disabilities. And we asked the questions of both the parents and the person with Down syndrome so that they could report on their own symptoms. We also used a set of measures from the NIH toolbox, the emotion scales. So we asked them about sadness, fear, loneliness, and perceived stress. And this is a set of scales that was developed for the general population. And we were hoping that, if these are, kind of good, reliable tools, if people with Down syndrome can complete them and report on their symptoms, then that gives us the ability to be able to compare their scores to the general population. So we can answer the question, are people with Down syndrome, kind of more or less likely compared to the general population to experience these things? And then finally, we compared that to a diagnostic interview. And this is where we went through a very structured, diagnostic interview, symptom by symptom, to try to determine, do they meet diagnostic criteria for one of these disorders? Okay. So what we found, so this is a bar graph that shows, kind of after we, went through that diagnostic interview, how many people met criteria for a diagnosable mental disorder. And so what you can see here in this chart is that at the end we have any anxiety disorder. And so 50% of our participants met criteria for an anxiety disorder. This is really high. We expect in the general population a kind of a lifetime prevalence is about 20%. But this is kind of current symptoms. We asked people about the symptoms that they were experiencing in the past month. And so this is a really high number. We see the highest of the anxiety disorders is specific phobia, those specific anxiety. It's a lot of fear of the dark, a lot of fear of storms, and then, some fears of animals, of snakes, of spiders, and that sort of thing. Social anxiety, generalized anxiety, and OCD were also very, very common. Depression, it was 15% of the sample. Studies of depression in the general population, like when we ask about kind of current symptoms, are usually closer to like 6 or 7%. So we're seeing about double the rate of depression as what we would expect to see in the general population at any given time. It's also interesting to note when people came into the study, we asked them whether or not they had ever been diagnosed with a mental health disorder. And they could check whether they had been diagnosed with depression or they had ever been diagnosed with anxiety. And so when we look at the people who currently meet criteria for a mental health diagnosis for anxiety or depression, only about a third of them reported that they had ever been diagnosed. So this suggests that nearly 2/3 of participants who have a mental health condition have a diagnosis of that by a doctor. So that these seem to be kind of flying under the radar for a lot of people.
Dr. Brown, I was just
Yes.
wanting to see if maybe you could slow down slightly for the Spanish interpretation.
Oh, yes, of course. I'm so sorry. Thank you for
No
letting me
worries.
know.
Thank you.
Do you want me to go back to that other slide?
Daniela?
No, I think it's okay. You can
Okay.
keep.
Okay.
Thank
Okay. And then this graph here reflects um, the NIH Toolbox scale. So this is the one that allows us to compare people with Down syndrome's score compared to a general population average. And so I'll kind of walk through what this graph means. So this line here reflects what's called a t-score of 50. And so this is the population average. So in a general population sample, most people fall along this line, this t-score of 50. T-scores of 60 and above are considered, to be clinically significant. And so what we see here are these are the means of our sample with Down syndrome. And the little bars on the top and the bottom are called error bars. And so what this shows us is that the majority of people with Down syndrome were scoring, significantly higher than the general population in loneliness. And I think this is relevant, with the World Down Syndrome Day coming up. Its major theme is loneliness this year, and we're seeing that yes, people with Down syndrome are reporting significantly higher loneliness compared to the general population. We also see elevated fear and sadness. Perceived stress was about average. We also see, and I find this to be fascinating, significantly lower positive affect. And we often hear about people with Down syndrome. People will say, "Oh, people with Down syndrome are always happy," which always gets lots of eye rolls whenever I say say that in a room full of parents of people with Down syndrome, because we know that's not the case. That people with Down syndrome aren't always happy. And what we're finding is that on average, yes, it's true. People with Down syndrome are less happy, showing less positive affect than the general population. And so I think that's a really important finding, because it contradicts that frequent stereotype that we hear. All right. We also asked about recent stressful life experiences. We asked people to report what stressful life experiences they had experienced in the previous 2 years. And as you can see here, the percentage of people who are reporting stressful life events in the last 2 years is really high, is really common. Now, the data collected for the study was during the pandemic. We kind of started before the pandemic, and then the pandemic hit in the middle of it, and we we had to take a little bit of a break, but then we kind of picked back up again. And so some of these things like school and work changes. Quite a few of those are pandemic related changes of switching to remote learning and going back to in person and all of that. But other stressors that report are kind of the deaths of relatives and friends. Some of those were COVID related deaths. Some of those were just the passing of grandparents or people from other causes. A lot of conflict with people, serious illnesses, a lot of bullying and abuse from other people. And so that was about 25% of people. So we see quite a bit of stressful life experiences experienced by people. So the next thing we wanted to look at was whether the total number of stressful life events that they had experienced in the last 2 years was associated with their mental health symptoms. And so here we have their self-reported and parent-reported depression and anxiety symptoms. And so the blue lines are the parent-reported symptoms, and the purple here are their self-reported symptoms. And then these are correlations. So correlation between kind of 0 and 1 is what we expect to see. And so what we're seeing is significant correlations. So that means the more stress that a person experiences, the more depression both they and their parent are reporting, and the more anxiety that they're reporting. So the parent reported anxiety was associated with their stressful life events. Their own anxiety, own self-reported anxiety, was not, is elevated, but it's not exactly statistically significant. It was kind of very close to statistical significance. So we're seeing that, yes, stressful life events, experiencing stressful things, predicts mental health symptoms in people with Down syndrome. Doesn't mean that they're like doomed to experience mental health symptoms, but it can influence those. All right. Next, I want to share a new study that we're working on to try to understand and measure symptoms associated with Down syndrome regression disorder. Okay, so Down syndrome regression disorder has been recognized, kind of over 20 years ago, but it's been receiving kind of, increased attention. It's associated with a rapid decline in cognitive and adaptive functioning, can include catatonia symptoms, and it may persist for years without prompt treatment. Studies that have been kind of coming out within the last few years show that the impact on their caregivers is also very significant. And unfortunately, a full recovery is less common. So most people, once they experience regression, the symptoms, last. They may experience some recovery with treatment, but we're still trying to find, ways to increase their recovery. So some challenges right now that the field is facing in understanding regression, for one is that it's likely underdiagnosed. We hear a lot from families saying that they have a hard time getting doctors to, recognize it. Most people don't have access to a specialty Down syndrome clinic, and so they go to just their community, primary healthcare provider who may or may not understand or have experience with Down syndrome. And so doctors aren't recognizing it. They have difficulties then kind of obtaining a diagnosis. And there are just kind of few studies that have been conducted yet, to really help us to understand, what is the natural history of, just kind of health in people with Down syndrome, and so, just to be able to show kind of just how, kind of atypical regression is, that it really is deviating from what we expect a person with Down syndrome to have. And so right now, so just within the last few years, the field has started to kind of, come together and create a diagnostic criteria for regression. And so currently these are the kind of main symptoms. So kind of altered mental status or behavioral dysregulation. So if we see major changes in their kind of thinking and behavior, some symptoms of cognitive decline where they're, have a difficulty with their, kind of memory or their motivation to do things. That developmental regression, that's the kind of hallmark, where they're losing kind of previously acquired skills, some language changes, kind of movement disorders, including catatonia, as well as new onset psychiatric symptoms. So this is a sort of thing where kind of all these things kind of come on all of a sudden, all at once within the course of, of just a few weeks or few months. Right now, it's a diagnosis of exclusion, which means that we have to kind of rule out other potential underlying medical causes. And so right now, the recommended kind of workup in order to be able to exclude that there's not some other, other treatable medical condition includes a lot of procedures. And these can be very, very expensive. And so we need reliable ways to be able to rapidly screen, for Down syndrome and regression disorder to figure out, who needs to go through these, these expensive workups, and who can we maybe kind of get to treatment sooner, who can we, kind of get to other types of treatments, like maybe that they've got depression and we can get them to a depression treatment, sooner and kind of rule out regression. So the purpose of this study then is to try to develop a new rating scale that caregivers can complete. And our hope is that that will help us to be able to, to kind of screen people and get people to treatment quickly. And so that's our goal. And so we're kind of developing this test, and we're kind of testing these screening questions. And then the next step is we're going to start looking at how does it distinguish between people with and without regression. These are our amazing collaborators on this project. So it's a multi-site study. So there's several of us from VCU. And then my amazing collaborators at Dr. John Santoro at Children's Hospital Los Angeles, and Dr. Stephanie Santoro and Dr. Brian Scott Coe at Mass Gen are collaborators on this project. And I'm so grateful to have them. Um, so the first phase of the study was we did some interviews with parents who, both have and don't have loved ones with and without regression, as well as some clinicians who are familiar with regression. And so we asked them to look through the questions that we were proposing to put on this measure, and ask them to think aloud and kind of describe their understanding of the questions. And then we kind of went through this process a couple of times until we had a set of questions that we felt like were nice and clear and understandable, and also were relevant to regression. And so we got some really valuable kind of insights from, from families during this process. So these are some examples of some of the symptoms that that caregivers described. And so talking about individuals who had been, kind of really socially involved, to then just, kind of being shut off in her room with the door shut. Individuals who lost significant amount of weight because they weren't able to eat or drink. People feeling, people getting kind of stuck in doorways, having accidents, even though they had been completely independent with toileting for a long time, unusual face and, facial movements. So it's a very broad constellation of symptoms that we're seeing, but very significant symptoms that are very distressing, to the person and to their family. So that's the first phase. So we're about to launch the second phase of this project. And so once we're ready to launch, we will send it out through the DS Connect registry. We'll also be kind of reaching out to Down syndrome organizations, asking them to get the word out and encourage people to participate. But our goal is to get at least 400 people to participate in the study, those who both have experienced regression, those who haven't, so that we can test whether or not this tool can help us to determine, the likelihood that somebody has regression or not. So we need people who are healthy. We need people who have, other things like depression or anxiety, and then we need people who have regression so that we can do that. So we want to know whether or not it can determine those groups of people. Okay, so the key takeaways from this talk. So we're kind of at the end. The key takeaways are that anxiety and depression especially are common, and that they often go unrecognized. Stress impacts the mental health of people with Down syndrome, and so we need kind of also better ways of recognizing stress and helping people cope with stress. Down syndrome regression disorder is a significant concern, and just broadly speaking, we need more research on the causes and treatments of mental health in people with Down syndrome. Part of that is needing validated tools to make sure that people get screened and get the help that they need. We also need these tools to make sure that the treatments work, because we use these tools to, test people before and after a treatment, and we need to know whether or not they get better from the treatment. And if they don't get better, we need to know that it was the treatment that didn't work versus we just weren't able to measure the symptoms properly. And then, of course, we need diverse families to participate in research, so that we can make sure that we improve the lives of all people with Down syndrome. All right, and so we'll be kind of keep an eye out on the DS Connect registry and other sources for information. If you're interested in kind of getting more information once we do launch the project, you can kind of reach out to us or scan the QR code here. Happy to kind of share more information, but we will certainly send it out through the DS Connect once we're ready. And then I just also want to say thank you, first and foremost, to all the families and self-advocates that have participated in these studies over the years. Like, we would not be able to do this and make these, discover these findings and, and use them to improve services for people with Down syndrome without people willing to participate in research. I'm also grateful to the NIH for funding these projects and to my kind of mentors and co-investigators over the years who have supported me and supported these projects. So thank you. I'd be happy to take questions.
This was wonderful, Dr. Brown. Thank you so much for joining us today. I see that the Q&A has been very busy, so I will just kind of work through some of these questions for you. I know that some of them may require additional follow-up, or if we don't get to all of the questions, we can follow up by email just to remind everyone. But the first question really talks about agitated catatonia. Can you talk a little bit about how that might be different
Yeah, how agitated catatonia might be different from like the
from
from
catatonia
the
just in general?
like the kind of more stuporous catatonia. Yeah,
Hmm.
I mean, it looks a little bit different, I mean, for everybody, but it might be somebody who like can't sit still, is moving around, maybe an increase in like stereotypic behaviors. So they may be, but like at a very, very elevated level, and so one of the things, so, I think there are cases, we don't know how often this happens, but, there definitely are case reports of people who, person with Down syndrome, developing, kind of on their kind of typical trajectory, and then, kind of suddenly have a new onset of stereotypic behaviors, kind of agitation and all that, and they get a diagnosis of like autism when those symptoms weren't there before. So sometimes it can kind of have those flavors to it, and and I think oftentimes when people think of catatonia, they think of that kind of more stuporous, effect of just the kind of shutting down, and they don't necessarily recognize that excitability and the agitation and kind of repetitive movements and and things like that can be a sign of catatonia. And so that's, yeah, hopefully that answered the question.
That's wonderful background for our families here. Someone else asked, kind of along those lines, if you suspect your teenager has with Down syndrome has anxiety, who do you go to treat that? What are the, can you maybe review some of the different professionals that you would have involved in your team?
Yeah, absolutely. So, like a psychologist getting a good, thorough kind of mental health evaluation, is ideal. It can be hard to find mental health professionals who have experience, especially adults, adult providers who have experience working with individuals with developmental disabilities, and so they may have some challenges kind of but finding a psychologist, a licensed clinical social worker, is helpful. I think probably depending on like the degree of severity of anxiety, so if it's, if it's just they have some like mild fears and anxiety, then, I think kind of any mental health professional could be helpful. If there's concerns that it's complex, that it's intense, it's causing significant distress and impairment in their life, then trying to find a psychologist, and in addition, getting that kind of making sure that kind of medical checklist is also good. Psychiatry is another route, to consider as well. And so, I mean, probably the first place to start would be reaching out to their primary care provider and asking for a referral, to a mental health provider. Yeah.
To both a psychologist and psychiatrist if medications may be needed.
Yeah, and you may have to, and unfortunately, you may have to just call around. I don't recommend saying like in the initial phone call, like, do you have experience with people with Down syndrome? Because probably they don't, and that might, be a conversation stopper. But instead, to reach out, and just ask, like, I'm looking for somebody to treat anxiety in my loved one. They're showing all these signs, and kind of bringing them in. So other places, to like reach out to your local Down syndrome association and ask if they have some recommendations. Just because through the grapevine, it may be that another family has found a psychologist that they like, and so getting that kind of recommendation can be really helpful. Each state has a what's called a UCED, a University Center of Excellence in Developmental Disabilities, and they often have people, across in different disciplines, and they may be able to reach out. So if you search for University Center of Excellence in Developmental Disabilities, it's a mouthful, and your state, then that should be able to kind of connect you, and that's another helpful resource to kind of connect, families with resources. So.
Wonderful. And on the DS Connect website, we're also trying to list some resources for families as well. So if you hear about a fantastic provider, please let us know. We can add those in.
Great.
Do you have any comments on the difference between DSRD and early onset Alzheimer's disease? So like age of onset, maybe some of the different symptoms that people should be considering.
Yeah, age of onset is a big one. And so, Alzheimer's, we don't see signs of Alzheimer's in people with Down syndrome really until they're like, kind of 40s and 50s. So a person who's 20 years old and exhibiting these symptoms, it is not Alzheimer's, and so that age of onset. Um, kind of what we're kind of currently thinking about, where the field currently is, is we're kind of thinking about like ages 10 to 30, is kind of peak onset, and I think in that emerging adult, like adolescence and emerging adult period, and why that's happening, we don't fully understand. We don't know if it's something about puberty, biological changes that are kind of happening with growing, whether, we think that, that stress may have, for some folks might be, part of it, kind of leading to, some, kind of inflammation that seems to have, some autoimmune characteristics. So there's a lot we are still learning and finding out about it. So, hopefully in a few years we'll have more. But yeah, but the age is the biggest thing.
Perfect. We have a lot of questions to get through, so I apologize if we don't get to yours. But we have a comment with questions about self-talk. I know this is kind of a common behavior, but when does it become concerning?
Yeah, I think to the extent that the person seems distressed, I mean, and I think this is true for any mental health condition, whether you have Down syndrome or not. We don't consider something to be a disorder unless it's causing significant distress and impairment, in a person's life. So, if it's upsetting the person, like if their self-talk is aggressive or agitated or is negative, they're making negative comments about themselves, then I would be worried about that. If their self-talk, and this I think kind of comes up too with like some of the fantasy, kind of intense, vivid fantasies that people with Down syndrome, kind of often have. Is it a source of enjoyment? Is it just that they're processing their day, they're processing things, or is it upsetting and distressing to them? I think that's the biggest thing, or is it kind of keeping them from participating in life like they need to, kind of participating in meaningful activities, participating in school or, work or a day program, or just enjoying their life. If it's interfering, then, we want to help them.
Absolutely. Absolutely. We do have a couple questions asking about either specific therapies that people should be investigating for anxiety or OCD, and then more specifically, what families can be doing even at home to help with some of these behaviors.
Yeah. So yeah, I mean that's a kind of
It's
another
a large
talk in and of
question.
itself. Yes. Well, so cognitive behavioral therapies, is the therapeutic approach that has the most kind of empirical support, the most research suggesting that it's effective. Kind of all of the other therapies, and that's my training, and that's my bias. People, have other therapies that they like, but from a research perspective, and what we know from a research perspective is that cognitive behavioral therapies, have the most evidence. And so that's a therapy where you're addressing a person's, kind of negative cognitive beliefs, and addressing kind of behaviors that may be contributing, to them. For people with Down syndrome, it tends to be a little bit more kind of a behavioral focus, and does include, kind of their caregivers kind of helping and supporting them. And so maybe like learning, developing coping skills, learning how to, do deep breathing, how to, how to manage those feelings while also very gradually and, kind of engaging with whatever it is that they're anxious, for example, or if they're depressed, kind of helping them to kind of get back up and get back engaged in their life, in order to try to increase those, those kind of the good feelings that we have by, by accomplishing things and doing things. So yeah, so looking for cognitive behavioral therapy, I think is would be what I would recommend in terms of types of therapy. And there are studies that show that CBT is effective for people with mild to moderate intellectual disabilities. And I know people are working on trying to, kind of further modify these interventions for people who have more support needs. But currently, currently the evidence suggests that yes, people with, with intellectual disabilities do benefit from these treatments. It's just a matter of finding a therapist that's, kind of willing to do that. For families, yeah, I think, just talking about emotions, encouraging, expressing, helping them learn the skills to communicate, their emotions and develop coping skills, is a really, really important one. But yeah, there's a lot more to I think to be said than that. I can kind of fit into a
That's fine.
yeah,
We can schedule a whole other webinar on supports that families can do at home. Maybe that's a great idea.
yeah.
I think we're getting very close to time, so thank you so much, Dr. Brown, for your time and expertise on this call. We will definitely, as I mentioned, get through all of these questions. It might take us a week or more to get back to you, but please don't hesitate to reach out if you haven't heard back and still have questions after this. But also along those lines, if you have researchers that you'd be interested in hearing from, please don't hesitate to reach out to our email and let us know. So I see lots of hand clapping and hearts. So again, thank you so much, Dr. Brown, for
Yeah.
your time.
Thanks. Thank you. It was a pleasure.
Thanks everyone for your time and attending. Have a wonderful rest of your day.